Selected for a prestigious European Society Fellowship in Peritoneal Surface Oncology, the first Indian gynecologic oncologist pursuing the course, and has attended and chaired and moderated sessions, been a panelist and given invited guest lectures at various national and international conferences. Apart from being a cancer surgeon, he also is very keen. His interest lies in music, theater, fine arts, and sports. He has various academic publications, radio programs, newspaper articles, public speeches, social media talks on cancer prevention, gynecologic, and cancer to his credit. So he is with lots of feathers to his hat, and we are very excited to have you, Doctor, today. So the stage is yours. I wouldn't delay more.
Zoom into go to Zoom. Is that okay?
You want the mic? So
Online now.
Just want to check, is Doctor audible to all the folks online?
Am I audible?
Give a thumbs up.
Hello, all of you.
Yeah.
Yeah.
Yes,
Right.
yes.
So, good afternoon, all of you. Thanks for this invitation. As I was telling you, it's always nice to share knowledge, number one, and also create awareness, and of course, network. So, what better place than a good place like partners? Just did a little bit of research work, given that you do quite a bit amount of work for the national and networking and digital marketing. So anyway, today I'll be speaking on cancer as a whole, initially to start with, and later onwards I will specify on gynecologic cancer. So as Mr. P told that I moved on from gynecology to gynecologic oncology. So this was a specialty which was still not very existing 10 years ago, 12 years ago when I started. So there was only one or two institutes in the country which were offering an exclusive training in that. There were many people still asking me even after I got trained, what is that piece? Can you tell me again? Gynecologic oncology, no, I can't spell it out. This is how it used to be. So anyways, it's mainly deal with female cancers. So cancer in women. So that's all about it. It's a study exclusively dedicated to these cancers. So I stopped doing cesareans and normal deliveries, and I only moved on to looking at cancers arising in a gynecological spectrum. So, yeah, cancer, as all of you know, I'm sure all of you are read about it, but let's know what is cancer all about. Like, it's a disease. So, cancer is a disease in which abnormal cells keep proliferating, they keep dividing uncontrollably and destroy the local healthy tissue. And it's usually classified by the site of origin. So cancer is like from where it is originating. So that's where we call it what type of cancer it is. There are about 200 types of cancers, many types based on the site of origin. And there are again subtypes in that amounts to a few lakhs of them. So that is the heterogeneity when you say about cancers. And yeah, very important is the last line that each one of us is born with the potential to develop cancer. Not to scare all of you. The point is like we have a potential because God has given us, okay, I'm a believer, so I keep using God. So, like we have genes, one to increase the growth of a cell and one to decrease the overgrowth of a cell. So basically, there's a balance between these two genes. That's how whoever is not developed doesn't develop. But wherever there is an imbalance in these two, yes, there is a potential. So you do whatever is. Can you change it here, please? Next slide. Yeah, next. So sorry for the, yeah. So with regards to the statistics, oh yeah, now it's working. Okay. With regards to the statistics, like, there are about 2.5 million people living with cancer, and every year over 7 lakh new cancer cases are registered. So for every 2 women newly diagnosed with breast cancer,
Go on mute.
first time I'm attending a hybrid. Usually it's always one on one. So yeah, the 1 woman dies of it in India for every 2 women newly diagnosed with breast cancer. Number of breast cancer patients will double by 2025. 1 woman dies of cervical cancer every 8 minutes in India, and the lifetime risk of developing cancer is 1 in 22. So these figures only represent the tip of the iceberg. Many cases go unreported, and because there are, especially in the urban areas, yes, there are. It is properly reported. It goes through the registry. We get the numbers, but in many of the places, I recently saw one who kind of diagnosed that she has cervical cancer. I told only because of the fear she did not come out for the treatment. So such cases can go underreported. So with regards to the top 5 cancers, in women and men, you can see the number 1 cancer currently in India is breast cancer, followed by cervical cancer. Earlier, cervical cancer used to top, and it's followed by colorectal cancer. Colorectal is basically the lower portion of large intestine. So even that is also on the rise. And ovarian cancer, which is my area of interest, special area of interest. And 5th one is oral cancer. So there are still many women, who are exposed either directly to tobacco, either by chewing, especially in places like Maharashtra or the rural women also, and also women who are spouses of passive smokers. And because of this also, oral cancer is also on the rise. Whereas in men, it's a different thing. Oral cancers are number 1, followed by lung cancer, stomach cancer, colorectal, and pharynx, throat cancer. These are the ones in men, because we generally men, there are more number of smokers. So yeah, if you see here, like there are many organs. See, the basic unit of the body is cell. A group of cells is tissue, and a group of tissue forms an organ. Okay. Very basic to understand. So each organ has 2 or more types of tissue. So there can be different types of cancer in an organ, different types, subtypes. We already discussed that there are so many subtypes. So if you see that there are more than 20 subtypes of breast cancers, more than 5 subtypes of stomach cancers, and there can be more than 5 types of head and neck cancers. But again, many subtypes. In the breast tissue itself, you can see, there is a fat tissue, there is a glandular tissue, there is muscle layers. So there are different components. So from each of them, cancer can arise and result in a different type of. So yeah, enough of scaring. So now that when it comes to the management, how do we manage cancers? Like traditionally, it used to be just that one doctor going to one doctor, diagnosis, and especially 20, 30 years ago, it used to be like cancer, nothing much can be done. This is how it used to be. But of late, cancer treatment, disease management has evolved so much, with a lot of research, with a lot of protocolization, things like that. That it is an integrated cancer care. If you see here, in the first circle, for example, starting from imaging, say a patient who gets a scan done, and followed by that, there is a suspicion that there is some extra growth of some tissue. So then after that, we try to use an ultrasound guided or a CT or MRI, whatever guided. We try to take a small bit of biopsy to prove that there is cancer. That is intervention radiology. Later on, the biopsy. The biopsy, send it for the pathologist who reads it and gives us a diagnosis. Later on, patient comes for surgery. Again, in surgery, earlier it used to be just one surgical oncologist, who used to do all types. Even now there are, but again it has evolved. Now there is a separate specialist for head and neck cancers, separate breast cancer specialist, separate one for gynecologic cancer, separate one for orthopedic cancers, bones and muscle cancer, things like that. So that surgery is done. So after surgery, again, a specific pathologist sees. Again, in India, especially in urban areas, like we're fortunate to have pathologists who are subspecialized only in gynaecology, intestinal basic cancers, things like that. So they give us more precise information of the cancer based on which the best next available approach will be taken. So that what we do, we usually discuss such cancers in something called as a multidisciplinary tumor board, wherein the surgeon is present along with the medical oncologist, who is the person who gives chemotherapy, along with the radiation oncologist who administers radiation. And so these are the people who sit together and finally take a plan of action is designed, and that is offered to the patient. This is not all. I said integrated. So wherein of late we also have somebody called as a psycho-oncologist, because already the patient is totally upset. Because not all places as such in Bangalore has. I mean, this has been more of a practice in usually tertiary care institutions wherein everything is in place. So psycho-oncologist is also there who takes care of the psychological aspects what a patient is undergoing. For example, I told you about a patient who denied treatment. So it is a loss for the family, but we have to see to it that she takes treatment. Right? So if there's a psycho-oncologist, he or she, they give a year to their man, finally, eventually make them undergo treatment. Comorbidity management. Patient may be having diabetes, hypertension, other things also along with the cancer. You need to manage that as well. Sometimes there is reconstruction, especially the cancers in the oral cavity and all. Once that is taken off, it has to again stop. The functionality should be restored. So there is some reconstruction that is done. Joint tissue is done. There's a specialist for that. A plastic surgeon who is trained in reconstruction. Rehabilitation. Throat cancers, patient uses the voice. There is a person who rehabilitates it, tries to tell them to regain the voice. Diet and nutrition, very important. Clinical nutritionists, we call them. So they are very important. And pain and palliative care is another which is very important. Wherein it's not pain involved, especially in advanced cancers. That has to be dealt with. That has to be taken care of. So, and sometimes there is a situation where nothing can be. I mean, to say there is no surgery possible, no chemotherapy which is useful, or no radiation that can be. In such situations, we just cannot leave the patient to die. We have to palliate, we have to alleviate the symptoms. Like, she may be having some cough, she may be having some back discharge. Trying to, improve the quality of life by doing something, for which a palliative and eventually sometimes home care. So these are all the different angles of other aspects of oncology who are there, improves the quality of the eventual cancer care that we give the patient. That's very important. I also mentioned about screening. I'll be talking about it later in detail. So how cancer manifests, now I'll be specifically speaking on gynecologic cancers. So if you can see the central figure there, so that's how the uterine architecture. So there is the cervix, the lower portion of it, the inner layer which is endometrium, the muscle layer, and lower the vaginal layer of the organs there. There are ovaries on either side, there are tubes. So likewise, they can be cervical, ovarian, uterine, vaginal, vulvar, fallopian tube cancer, peritoneal cancers, sarcomas, different kinds of diseases. There is also something called as pre-invasive or pre-cancerous lesions that can happen in cervix. So I'll talk about it a little later. Who gets any woman is at risk? Any woman is at risk to get out gynecologic cancer, but the risk factor increases with age. So it's not the same for all cancers. Okay. So of these cancers, the most important one are cervical, ovarian, and top three ones. These comprise nearly 90% of all of the gynecological cancers. So I'll be speaking mainly giving an impetus to those three cancers. So ovarian, mainly it is through a genetic, that is the genetic cause. That is the only cause which has been noted. Whereas for cervical, it is a virus called as human papilloma virus. the same virus, it has hundreds of types. There's so many different subtypes. There's high risk and low risk types. The high risk types are the ones which cause the cancer both in women and in men. In men, it can cause anal cancer. Especially we see that in, homosexuals, especially, they are the ones who get the anal cancer and rectal cancer. So the human papillomavirus is really for that. Whereas the endometrial or uterine cancer, obesity, hormone treatment after menopause, some women, especially in the West, there is a very high incidence of usage of hormone replacement therapy after the menopause. Because after menopause, they lose their hormone. So they are like, I still want to have a active sexual life, or my bones are getting brittle and I'm unable to do I have too much of mood swings. So in such situations, exaggerated menopause when it is there, they tend to use hormone treatment. So again, that has to be used with caution. So it's mainly the Western, not that Indians don't use here also, but somehow our ladies tolerate menopause much better than the Western, is what we see. And high fat diet, smoking, drinking, diabetes, hypertension, and almost same for vaginal and vulvar cancer. So the various warning signs. So now this is only in brief I'll be discussing. I'll be discussing in detail about in the coming slides. So abnormal vaginal discharge, bleeding after intercourse, intermenstrual bleeding, bleeding after menopause has set, lower abdominal pain, pelvic pressure or pain, sometimes abdominal bloating, and changes in the bathroom habit. There's sometimes a woman can notice some rash or ulcers or warts in private parts, or there's some itching or burning. So these are the various in a holistic way I have presented in this slide. So warning signs are basically not the same for everyone and for every cancer. It can be different. She thinks that that lady had it, she had all these things, I don't have all those. It may be. So going again, these will be a little elaborate. I'll try to concise, make it as concise as possible. So early stage and the late stage. So early stage, many a time, many cancers might not have any symptoms. Usually, the advanced cancer obviously will have some or the other symptom because of this the patient comes to the doctor. Till then, she'll be assuming that it is because something is happening. Heat up again, my body is very getting heated up or things like that. And she eventually thinks that, okay, let me see the doctor later. This is how they tell you. At least a woman you will know, but men they'll learn, especially what their mothers go through, what their grandmothers go through. You will never. So it's very important for people. I hope there are many people online also, men who are listening to this, because you are busy here. So and women don't tell it out. So we need to be aware of this. So there can be sometimes vaginal spotting after sexual intercourse, intermenstrual bleeding, foul smelling vaginal discharge. These are the early symptoms which can be there. Whereas when it advances, then there can be other symptoms like weight loss, fatigue, blood mixed vaginal discharge, pelvic pain, back pain, leg pain. In the worst case scenarios, we have seen all these things also. Vagina, spontaneous fracture. That's only in stage 4. But again, yes. In ovarian cancer, early cancer, there is almost nothing. It is almost always incidentally detected. The lady goes with some problem with her doctor. Doctor says, okay, get one scan, or she does a clinical examination. And then they find that, oh, there is a big ovarian cyst, ovarian tumor which is there. This is how it is usually incidentally diagnosed. If not, because 75% of ovarian cancers are diagnosed only in advanced stage, only 25% in early stage. So that's why it's called as a silent. So if at all there are some symptoms, it can be abdominal bloating, pelvic or abdominal pain, decreased food intake. Especially I used to eat 2 chapatis earlier, now I can't eat even half, I get full, my tummy gets full. Sometimes urinary frequency, urgency, I feel like doing more number of times. Other symptoms again, upset stomach. See, there are so many things which coincide with a general gastric. People think that the gastric ki tarah hai, so it must be something like gastric. I'll take an attack or something like that. This is how many people do. Many people, or they go to a general physician or a GP. They will prescribe a gastric medication. This is how it is. So those are the kind of specific things. With ovarian cancer as such, abnormal bleeding or gynecological problems are not much seen. It's more of gastric, abdominal related. So that is what is. And endometrial cancer, very classical. Any woman who bleeds after menopause, by rule book, it is advanced. She should not. Menopause ho gaya hai, 48, 50 years, 55 years, whatever. Menopause is ensured. After that, she should not bleed. That's a rule. If she bleeds, please take. Very simple. That also many ladies think that, especially in the rural work, like they think that, sir, my heat target to that, so I ate some food and I drank a lot of water. This is how they think. It's that fact. Recently, it's so sad. One of the patients, her son, again, who was like he's Mauritian. His mother, like she was assuming that she must be something. Literally, and goes to the doctor, nearby doctor. Again, lack of availability for doctor. That is also another problem in our country. Not all places. You're all working here. You're all having a decent life. But whether the same access to healthcare is there in your home place, no, it may not be there. So she goes in some quack or somebody who sees giving her medication. 8 months ke baad she comes to me in stage 4. Very difficult. So that is the reason. At least we need to keep talking to our parents. They are very innocent. All patients are innocent. They don't. Patients are very innocent. They will assume, especially women. I tell you, they keep thinking, hey, it must be this. It must be this. All their importance is for the family. They will never give any importance for themselves. Most of the women I see. So again, these are the same, almost similar complaints what we see in endometrial cancer. Vulvar cancer also. Vulva is basically the private parts, the outside private parts, which are covered by the undergarment. That is vulva. So again, there's itching, burning, bleeding, or some skin changes. Again, this is something which sometimes are not noted initially. They apply with ointments or some powder. Again, they delay. These things also should be immediately attended. Vaginal cancer, almost the same thing as cervical. There's again another group of cancers which arise from the muzzle of the uterus, muzzle portion of the uterus. The sarcoma, small number, around 2 to 5% of overall cancers. Then this is one thing which I would like to tell. Many women actually, fibroids are quite common. You might have heard. I have fibroids basically do not turn into cancer. Only 3 or 5 in 1,000 women it might turn into cancer after many years. But otherwise, fibroids are something. But of late, I have been seeing a lot of women, especially having undergone some fibroid surgery, some new cancers. Exact cause, the reason is very difficult to ascertain. But again, so sometimes, that's why I tell, if there is a growing fibroid, if it's increasing in size disproportionately, then definitely we have to have sarcoma. And, again, bleeding after menopause, and if the uterus size is significantly enlarging, abnormal vaginal bleeding, these are the signs of the uterus. Coming to this factors, we already saw, and just elaborate what you people should do. So as I told, it's human papillomavirus, high risk and low risk types. Low risk are what? Simple warts and all that can cause. High risk and cause. So for cervical cancer, these are the risks. Early age of sexuality, early age of marriage, having multiple sexual partners, spouse having multiple sexual partners, multiple pregnancies, poor genital hygiene, smoking, tobacco consumption. These are the risk factors for cervical. Basically, the earlier an unprotected intercourse with some HPV, the HPV goes and that multiplies, especially when the cervix is still maturing. During that time when the HPV strikes, 90% of women usually due to the body immunity, HPV is it's defeated. But in 10% women, especially who smoke, who don't have a good hygiene, who earlier have early pregnancy, very early pregnancy. In the rural side, we see 16 she gets married, 17 one child, 19 another child, 20 tuberculosis. This is how they, so such women are at high risk. And this is a cancer which is the only preventable cancer. Only preventable. Because the virus does not immediately cause cancer. It takes about 20-25 years to cause cancer. So we have that long time to easily detect it. That is what is called a screening, which I talked about it. And for ovarian cancer, it's known to be the silent killer, which I already told. Advancing age is a risk factor. Family history of ovarian cancer, breast cancer, and uterine cancer. This is one very strong. If anybody has a family history, please think about it. And this is one more thing, especially today's women who are again the ambitious, who are more than men what we see. Yes, it's very good. Professionally, you are doing excellent. Kudos to it. But at the same time, I've seen many women who delay their pregnancies and who usually, 35, 40 k baad, they start getting the treatment, taking infertility treatment. There are so many drugs which are used. Again, they may trigger the formation. So these are all the risk factors. And obesity and again hormone replacement. These are the things. So whenever there is a pregnancy happening, I don't think so that it should be terminated. I have seen so many women doing, like, no, I am actually busy now, so I have to go. I'm still going up my career growth. I mean, it's good, definitely professional. But again, when something happens, it's not good to always keep pushing. Because infertility is one of the highest risk factors and breast. For endometrial cancer, there are multiple risk factors. I just keep on telling you, early menarche, somebody who, especially in today's world, we see children, girls getting matured at 8 years, 9 years, that early, and women who menopause very late. These are also risk factors. PCOD, one of the commonest things. PCOD, I don't think that's very important one. PCOD, polycystic ovarian disease. Many of you might have encountered that. Obesity, diabetes, elderly age, hormone replacement. Then high animal fat, Caucasian women usually are at high risk. In the US, this is the number one cancer. Unlike in India, this is the number one cancer. There they are like 150 kg, 180 kg also there. They very high chance. Family history, personal history, and sometimes earlier radiation also. Vulvar cancer, increasing age, HPV, smoking, sometimes HIV because it decreases the immunity. And yeah, history of pre-cancerous conditions. As I told you, those itching things or burning, sometimes that can be a pre-cancer. It is not frank cancer. Gynecologic cancer is one good thing. I mean, from the clinical perspective, is that it doesn't progress straight away. It takes some stages. It goes to pre-cancer and then it goes. So pre-cancer, if it's there, yes, that's another risk factor. And vaginal cancer again, biomass is the same thing. Smoking, inspection, same thing. Yeah. Sarcoma, again, history of fibroid, previous radiation therapy, and especially for breast cancer, they use something called tamoxifen. That can be a risk factor. African American women have twice the risk. Genetics, there is some condition called retinoblastoma, a tumor of the eye that develops in children. Those people, the children, the girl child, again, maybe at risk. She has that retinoblastoma. And women who have that. So these are the ones. So how to prevent? Now I'll speak a little about screening. What is screening? Screening is not a test like, for example, you feel that I'm passing urine a lot of times. I'm feeling very thirsty. So you suspect that, okay, I might be diabetic. So let me go and check my blood sugar. That is not screening. That is a diagnostic test done to see whether you're diabetic or not. But screening is a test that is done in normal individuals who do not have any symptoms. Okay? It's a strategy involving performance of a test in normal individuals or a specific population for detection of disease or precursor. This is why this is a screening. Cancer screening aims to detect cancer before symptoms appear. This may involve blood tests, urine tests, or other tests of medical. So in cervical cancer, very, very simple test is, I'm sure any of you can tell, especially the women. So pap smear is the screening test that we do to detect whether that lady has a precancer or a frank cancer. Okay. So who should get screened? Women with moderate risk. There are women who are at moderate risk. Low risk are the ones who don't need to get screened. So I'll just be about moderate risk and high risk. Moderate risk, women with history of breast cancer diagnosed by age 40 or a close blood relative, sister, mother, aunt diagnosed with breast cancer. Women with history of infertility or assisted reproductive therapy such as IVF. Women with history of endometriosis. This is one condition which I'll speak about later. History of hormone replacement therapy. Women with high risk are the ones who have are the women who work with first degree blood related with ovarian cancer, personal history of breast cancer, or even breast also, ovarian and breast, family and personal history of breast cancer, known mutations, BRCA1, BRCA2, or other familial cancers. What is this BRCA1, BRCA2? Let me ask a question to the men. Who is your favorite Bollywood celebrity? Not currently acting, who used to act earlier. One notable Hollywood, not Bollywood, I'm sorry. Celebrity. One of she was voted as the best most beautiful woman some time ago. Exactly, fantastic. Angelina Jolie, she is a Jew basically. So Jews are not Ashkenazi Jews are the one population who have a high incidence of this BRCA mutation. So that's a gene basically. So that is mutated. I mean, in some. So those people who are mutated have a high chance, very high chance of developing breast cancer or ovarian. So Angelina Jolie, what she did, she got both her ovaries knocked out and both the breasts also knocked out. So that was a big debate. There was quite a few people at that time that, oh, if a woman is detected with that, should she get both the breast and ovaries knocked out? Ovaries, so yes, especially after she's completed a family, but breast. Later on, the consensus was that breast, even in the ovaries itself, will reduce 50% of development of breast. So that's why this mutations in BRCA, if there is something, you have to, I mean, that person has to attend a genetic counseling and undergo whatever the preventive strategies, which I will tell you. So, what are the different types of screening? For 21 to 65 years, you do a pap smear or a HPV testing, and rarely a colposcopy. This is for cervical cancer. So, these three things you should know: cervical cancer, pap smear, HPV testing, and a colposcopy. Colposcopy is again not if there is abnormality in pap smear or HPV, then only we do colposcopy, not as an upfront test. For ovarian cancer, in those high risk individuals whom we discussed, you got to do a transvaginal testing and an ultrasound scan of the pelvis, CA125 blood test, and do a mutation, that genetic testing, whether there is a mutation. So vaccination, very important. You might be having kids, daughters, especially between the age group of 9 to 16 years. Cervical cancer vaccination is very, very important. Now, even boys we offer, because it is between the girls and the boys. It can be, it is transmitted from the man to the woman or from the woman to the man. So that is the reason. Even for boys aged 9 to 16 years, we offer. In some of the countries, it is mandated, especially in Australia, Canada, it is mandated. The government sponsors and it is in the universal immunization schedule, it is incorporated. In India, because our vaccine is still under progress, it will be probably by this year and or next year we will be getting it. So currently we are using the funds which are manufactured. So that's the reason we are not giving to under the government schedule, but we are offering it. It is mandatory that there are two types of vaccine. I won't go too much into detail about these things. I just want you to know that between 9 to 16 years is the best time that you vaccinate. But it is recommended even up to 45 years of age also a woman can be vaccinated. Okay, especially if she is HPV negative. Even otherwise, she is protected. It is protected. And but only thing is, protection is best when it is done between 9 to 16. This is what you do. So again, there is something called as pre-cancer. So that is also detected by pap smear and the HPV testing. So if there is any abnormality, as I told you, for colposcopy or some simple surgeries, also that can be done, which can prevent that development of that pre-cancer to cancer. Simple surgeries that should be. You don't need to knock off the entire uterus. You can just remove that portion. You can use laser or something like that to remove that affected portion, especially if there's a pre-cancer. And ovarian cancer diagnosis is ultrasound, CT scan, MRI, PET-CT. Treatment is mainly by surgery or chemotherapy or radiation. These are the three arms of treatment in cancer. These are the three arms. So for whom to do and all, this is not a part of today's discussion. Usually early, very simple common sense. Early stages of cancer easily operable. May or may not require chemotherapy or radiation. Slightly advanced, question of surgery is, the role of surgery is questionable. But in ovarian, even if it is advanced, we still will do give chemotherapy and then we do surgery. So surgery is there for ovarian. But for cervical cancer, usually they go for radiation. Survival rates, again, I won't go too much. If you can just see in earlier stage, you can see the 5-year survival is about 93-80%. So that's quite fantastic. But when it comes to first 4, it is just about 15%. That is 15% of women survive till 5 years. The rest 85 would have succumbed within 5 years. That is what. But whether it is when cervical cancer stage 1, 1 year, it is about 93% continue. Even 10 years, they keep continuing. We don't see relapses in stage 1 at all. We may see in a very small. So ovarian tumors, again, the 5-year survival is very good in first stage, but look at the fourth stage, third stage, it is about 45. 75% of cancers I told you present in this stage, stage 3C. So where we do surgery and chemotherapy, whichever sequence is first. But whatever you do, survival rate is just about 45%. That is the reason we have newer modalities, which we said that I know I'm trained in, that is high peg. We heat the heated intraperitoneal chemotherapy. We heat the chemotherapy and circulate it after surgery. Or sometimes we aerosolize the chemotherapy. The liquid form of chemotherapy is aerosolized and that is circulated inside the abdominal cavity. So these are the newer approaches, that surgical approaches that are available now, which have further increase in survival rates. The patient survives a little longer, and they are so those are the things which are available now in India. Earlier it wasn't. And yes, in advanced stage it is quite difficult. There are different types of ovarian tumors. I won't put details of that. For uterine endometrial cancer, it is very good. Usually, I keep telling my patients, if God has written on that if you're destined to get a cancer, then better you get an endometrial cancer in the early stage, because usually they do very well. This is just more than like I have never seen a woman who relapses in the first stage. They do very well, but advanced stages, yes. Like the one I said, that Odisha patient, she came in stage 4 and she did not live beyond 6 months. That's how bad it is. In sarcomas, almost the same thing. Briefly about breast cancer, which is very important. Although I am not an exclusive specialist, I do diagnose, and I do initiate the treatment approaches. So, yeah, breast cancer, almost 48 patients are below the 48% of patients are below the age of 50. Very scary. Who gets? These are the important things. Advancing age, family history, early age at menarche, late age at menopause, obesity, hormone replacement therapy, not having insulin, alcohol, smoking. These are the risk factors. Look at those protective factors. Age at first childbirth matters. The earlier the age of first childbirth, it is better. Then breastfeeding. Nowadays, people, especially working women, don't find time to breastfeed. You have to ensure that you have to use your maternity leave to breastfeed, and breastfeeding is very, very productive. Exercise, very important. Weight control and high calcium vitamin. These are the things which are protective factors. Manifestation, it may or may not manifest in every woman. I mean, each woman might have a different kind of complaint. Very luckily, some patients, I'm finding something. Common thing is that they might, there's a lump there. I wasn't feeling it earlier. Now it's consistently present. Usually there can be lumps, especially in women who menstruate. There can be lumps which are inconsistent. Once they might feel in the right breast, sometimes they may feel in the left. They are inconsistent. But consistently, if a woman feels a painless lump, is that has to be. And spontaneous nipple discharge, bloody nipple discharge, ulceration, swelling or mass in underarms. Again, that's another thing. And retraction of nipple. If the nipple gets retracted, that is another thing which is important. This is one figure which tells, like, there's a hardening, some hardening. Here there is some pinching of the skin. There's a skin erosion. There's some redness which is there, or presence of some new fluid, or some dimpling, or bumpiness, or some growing vein. Sometimes there can be a vein that is growing here. Or if there's nipple retraction, asymmetry of the breast, or orange peel skin. This is one of the common things in advanced breast cancer, which we call as purely orange as French, and invisible lump. These are the various ways by which a breast lump can manifest. Very important breast self examination. I go on not going to the depth of it because all of it can Google it and see. And who should get screened? Very important. 20 to 39 years, breast awareness is important. All this is all what is needed. And a clinical breast examination and ultrasound yearly is all what is needed. And if it is 40 to 70 years, every 2 years clinical breast examination, mammogram every 2 years. And above 70 years, clinical examination, mammogram also. So what we had for screening. Again, for screening, it's only 2 cancers. When the cervix and breast, these are only 2 cancers that we screen for. So yes, how to get diagnosed? When the mammogram is done. Mammogram is nothing but an X-ray which detects some kind of calcification. See here, there is some whitish formation. So that is calcification. Sometimes there can be specks of calcification which are seen, and that those are diagnosed. Now we also have some advanced things like digital breast on and various treatment options like surgery, chemotherapy, radiotherapy, hormone therapy. These are various arms of the cancer. Okay, each one we do different things. Especially earlier ones, we do something called a vacuum assisted cancer. We do something called a sentinel mode, wherein we try to inject a dye and see whether it goes to the appropriate node, so that we remove only that involved node, not the entire. Because many a times, breast surgery, we see that big surgery is done and the lady develops that arm gets over a period of time. So to avoid that, we have recent ones, latest ones. So yes, coming up to the end of my talk. So to remember, if you really love someone, ask for a breast cancer. Don't wait for symptoms; it's too late. If a member of your family has breast or ovarian cancer, get yourself checked. These are the ones. And very important for preventive strategies for gynecologic cancers. The top 3 cancers: cervical cancer, avoid high risk behavior, regular pap smear, vaccination, avoid smoking with tobacco. And for ovarian cancer, be very cautious if there's a family history of ovarian or breast cancer. Please tell them to undergo genetic testing and screening. And if for uterine cancer, avoid obesity, diabetes, hypertension, avoid delayed pregnancy, good lifestyle management. So these are the ones, and I'm sure there will be questions. Thank you. Thanks for your time and patient listening.
Question time.
It's very common to have either endometriosis or adenosis. So every woman who most of us still have it common. So how should we handle it? Is it very common or every woman who has these symptoms is bound to get
Very important question. I'm sorry, I told at the end of my slide I'll be speaking for it. Rather, positive, and yes, it's good that you got it right now. Endometriosis is basically presence of that inside layer of the uterus that is present elsewhere also. That is it. Commonly used to ovaries. Usually, just like I told you, cervical cancer has something called as precancer. The HPV goes into precancer. That becomes cancer. Like that, endometriosis is not a precancer. So don't be afraid of it. Endometriosis has a different modality. But there have been certain types of cancers which are seen commonly in endometriosis. Doesn't mean that endometriosis leads to cancer. Not at all. So don't be afraid of that with regards to cancer. But there are certain types of cancer that can develop in the background of endometriosis. So that is just about 1%. So remaining 99%, endometriosis does not turn into it. That is something which you do. Endometriosis as such, depending on the symptoms we treat, that's another actually sometimes worse than cancer. Especially if for a surgeon to operate in the advanced, but not all women have the advanced. Just about 5 to 10% have advanced. So you have some form, you may have. That's quite manageable. Adenoviruses, endometriosis is present within the uterine tissue, the muscle. Adenoviruses is also, again, if it is minimal, if it is not, there's no chance that it could turn into cancer. It's not a big cancer for sure. Next thing is, yeah, it may cause gynecological problems, something like that, because of which it may have to be addressed. Sometimes we address it by through some medication, or if it's not responding to medication, do a simple surgery after say 45 years. 40. Usually easily managed. No questions means either I was too good or I was really bad. You can take off the I mean, technically radiation is harmful, but whatever the conventional machines that we use, it is all very, very approved by the AER, the Atomic Energy Regulatory Board, all those things. So they are all very much regulated, very minimal amount of radiation. So it's not that you have to be worried too much about the amount of radiation. So it mainly, yes, only those women who are with family history of breast cancers, they are the ones who regularly will get a mammogram, but not others. And it's a yearly basis. Very frequently, there are some centers wherein regular CT, PET CT is done very often. Yes, they may sometimes carry it, but again, it's all very regulated and not much.
Any questions? On that?
Maybe an ultrasound really, or a blood test really, like how to go on.
Depends on the age. So from 21 to 30 years, 30 to 65 years, and after 65 years. These are the three groups of people. 21 to 30, generally, there is nothing much that is. There is nothing much. In terms of only, because as I told you, cervical cancer, if it has to be detected after an HPV infection, it takes about 20 years. The HPV infection takes place here around 16, 18, 20. It is cervical cancer is not yet. That's why we just go past here. Like married. For breast, as such, still 30, even if you do, the chances of picking up a lesion is very, very minimal. So it is not recommended strongly. Probably you can just get an ultrasound. That is all is. But again, that is not recommended on a yearly basis. Yes, if there's a family history, it is. If there's a family history, one of your aunts, grandmother, mother, sisters, anybody like that, then yes, 10 years before the onset of their diagnosis. For example, if the grandmother had a diagnosis at say 60 years, then from 50 onwards, regular mammogram, yearly mammogram. That's all. For somebody who does not have any risk, the chance of getting cancer is also not much. All said and done, spoken so much about cancer, it doesn't mean that it has to be very seriously. That I mean, it's not a intimidating. I don't try to intimidate you with stuff. I just want to get an awareness that there are many symptoms. Yes, be aware about it. But it's not to be taken that a general population also can get a very high risk. I mean, is at a very high risk of getting cancer. Not like I told you to the risk factors. Those are the risk. Go to slides before. Those are the important things which you have to look for. So, if you are doing these things, that's enough. That's okay. And risk factors, I already told you earlier itself. There are so many risk factors, especially for each one. So, who is screening is basically 21 to 65, pap smear alone is especially if they are married. After 30 years, the HPV test also is required. And between 25 to 65, if again the same thing, pap smear and HPV. Only to diagnose further, we go for post. For ovarian cancer, only if there is a family history. So otherwise, there is nothing that I can get from ovarian cancer. Nobody knows how to get. Recently, there was a trial that was done in the UK. They studied 2 lakh women. That is the largest trial done for screening for ovarian cancer. So in that, they found out that doing a scan and CA125 and not doing a scan is almost panicking. If you do it, it's not that you're detecting early ovarian cancers more effective. No, nothing like that. In both the arms, it was almost. That is the reason we don't have a recommendation that every lady has to undergo a scanning or a CA125 test, CA125 blood test to detect ovarian. No, it is not. But if there is a family history, please get it done. Probably on a yearly. Only not.
Okay, I have a question. So after menopause, how many months later should we see a bleeding? It's a risk.
See, menopause is 1 year. It should have stopped. That is enough. That is usually in some women it gets irregular, and then after the last cycle, if there's a 1 year gap, it means that it has menopause. So after that, anytime she is bleeding, then it is a postmenopausal.
So 1 year gap and then we see.
Yeah, and then if there is a bleeding, it accounts to a bleeding. For example, last cycle was say somewhere in 8 months ago, and now she had it is still not done. It means that she is having this cycle later than what she had last time. That's all. 1 year is the gap for menopause.
So, doctor, I think we are mostly hearing that lifestyle is cause for many diseases. What is your recommendation in terms of looking at our lifestyle or managing it well? I know there is exercise and habits, etc., but would like to hear from you. What is the top 3 or top 5?
Yeah, it's very prudent question. Yeah, we easily, generalistically, we tell it's a lifestyle. So each person is different. For example, somebody who's doing night shift, I cannot tell them do an early morning job. Right? I mean, it's again customized to each person, but on a general note, a good amount of, I would like to call it as a holistic way of looking at it. Holistic way is number 1 is food. So you are aware of what to eat. There are vegetarians, non-vegetarians. Each one, food, there is no difference that if you eat this, there's nothing. Only thing is, those animal, for example, if you saw in a few of the slides, animal foods with very high fatty content, probably. Usually, sometimes red meat. For example, I am in Kerala. So in Kerala, I have seen the top 3 cancers were different, or the number 1 cancer was different. Only the eating habits there are different. Whereas I was in Maharashtra, there again eating habits were different. There the cancer number 1 cancer was different. So it depends geographically, and it depends to the which part of geographically is number 1 and what job you do. So for urban folks, especially to address this audience, yeah, a good amount. At least 30 minutes of brisk walk, or jog, running, whatever physical activity. If you really burn out your fat and sweat well, number 1. And next thing is food. Generally, high greens. Greens are good, and whatever is grown on plants, that whatever is manufactured in plants, that will be fine. So this is again another good thing. And binge eating, junk, all those things that we generally tell actually And next thing is moderation of things like smoking and alcohol. Smoking is any day dangerous. Smoking is the only purely causative factor that has been identified in this world that it causes. Smoking is something which causes cancer. Alcohol in moderation. Again, each country has its own. So generally, if you ask the United Kingdom, the UK, they have they're drinking 14 units of alcohol per week. If you exceed that, this is a simple formula for all of you. Like more than 14 units of alcohol per week is proven to have deleterious effects on it. Be whatever. If you restrict with that, it's still moderation. Next, number 3. Number 4 is exercise cycle, diet cycle, vices cycle, or habit cycle. Next thing is, probably if I have to say holistic, because I'm a believer in that, I think you should help me with it. Because I feel that I tell so many of my patients, life is life. This is my one line. It doesn't spare anybody, however good you are. Biggest example is infection. We don't know how it is. But all said and done, luck favors those who put efforts. So people, but still I see, just in what I see every day when I go. This one, nearly 70, 80+. Every day morning, still fine. So, but does it become a role model to us? No, I should. He's lucky. That's all. Being like that, not that even I'll be happy doing it. So it's probably by knowledge, we should know what, and having that strong connect is also. So holistically, these are the top findings which I. Online.
The online folks are very silent today.
Okay. I bored them.
No, it was very informative and thank you for the detailed information shared. And awareness is always any day better. I think we are all well aware today. Yes. Thank you so much, Dr. Roopesh, for coming and educating us on this. I request Savita to just give a moment of Dr. Roopesh.
I currently have I have a clinic, but I visit many hospitals. And many hospitals. I go to different hospitals, but any information, regarding cancers and anything, my website is there. You can have a.
Can have one photo. Yes.